Let's discuss a very important topic, celiac disease. Celiac disease is a chronic autoimmune disorder which is triggered by environmental agents such as gliadin, which is a component of gluten, and it is usually in the genetically predisposed individuals. And this gluten is usually found in wheat and other grains such as barley and rye. Often develops in childhood but may develop at any age. If we talk about genetics, no single genetic marker exists, but majority of the patient have variant HLA-DQ2 and HLA-DQ8 alleles. These predisposing HLA risk alleles are necessary but not sufficient to develop celiac disease. Associated conditions like other autoimmune disease, like whenever any autoimmune disease occurs, it always occurs in a group of autoimmune disorders, and it could be diabetes mellitus type 1, which is the most commonly associated. If we talk about the epidemiology, it primarily affects the whites in the northern European century, and it is like more than 1 is to 5,000 in North American. If we talk about the pathogenesis, upon exposure to the gluten, which we talk about, the gluten was a risk factor. It is an abnormal, it will give an abnormal immune response that leads to production of several different autoantibodies that affect different organs, and this leads to the formation of immune complex in the intestinal mucosa, primarily the small intestine. And presence of immune complex the presence of the immune complex, it will promote the aggregation of the killer lymphocytes, which causes mucosal damage, and this leads to loss of villi lining, that is known as villus atrophy, which is very commonly asked in the questions. What you see in the histology, it is usually villus atrophy, loss of the villi, and proliferation of the crypt cells, and it is also known as crypt abscess. And damage to the villi lining leads to dysfunction in the nutrient absorption, and that leads to malabsorption and anemia, which is most commonly seen. Now let's talk about the clinical features. Steatorrhea, which is most common feature, it can lead to fat soluble vitamin deficiency. What are the fat soluble vitamin deficiency? A, D, E, K. These are the fat soluble vitamins, and deficiency is usually seen here. Abdominal pain, bloating, flatulence, weight loss or failure to gain weight, fatigue. Some patients are asymptomatic. Repeated infection if IgA deficiency, which is common in celiac patient. Anaphylaxis if transfused by IgA containing blood products. This is very important, that when we give blood transfusion to a patient who is required, and if it contains IgA, we need to do anaphylaxis, because if IgA will trigger the celiac disease. The physical examination will show abdominal distension, pallor, mouth ulcers, short stature, and most important is dermatitis herpetiformis. It is a pruritic red papulovesicular lesions commonly on shoulders, elbows, and knees. It is due to IgA deposits, that is anti-epidermal transglutaminase in the upper dermis. It is very important point. If we talk about the diagnosis is based on clinical symptoms and confirmed with small bowel biopsy, and we talk about the biopsy finding, which was the villus atrophy. If there you can do a serological blood test. Best initial test is to see the antibodies, which is anti-tissue transglutaminase IgA antibodies. Anti-endomysial IgA antibodies are also seen. Test for IgA antibodies will be negative in those with IgA deficiency. For patient with IgA deficiency, the deamidated gliadin peptide known as DGP IgG testing is available. Positive serology requires small bowel biopsy for confirmation of the diagnosis. Let's talk about the biopsy, which can be done by the upper GI scopy. and it is the best confirmatory test. At least 4 duodenal biopsies are recommended. Endoscopic features including loss of folds, visible fissures, nodularity, scaffolding, scalloping, and prominent submucosal vascularity are seen. Histology, we again talked about, it would be increased intraepithelial lymphocyte and plasma cells, atrophic mucus with loss of villi, hyper enhanced epithelial apoptosis, and crypt hyperplasia. HLA testing could be done. The lab could be CBC, iron testing, folic acid, vitamin B12 to evaluate the level of malnutrition or the malabsorption. We also prefer DEXA scan to identify the risk for fracture or need for bone protective mechanism, because we talk about fat soluble vitamin deficiency, which also has vitamin D, and that's why patient is at risk of fracture and osteoporosis. Differential could be inflammatory bowel disease. Distinguishing feature is based on the histologic appearance of the biopsy. Irritable bowel syndrome, distinguishing feature will be negative biopsy result in which there will be normal biopsy. If we talk about the treatment, it is mainly the first line is gluten-free diet. It allows healing of the intestinal mucosa and resolution of all symptoms, eliminates the heightened risk of osteoporosis and intestinal cancer, and then dietary supplements as we talk about because of the fat soluble vitamin deficiency. Second line, steroids or immunosuppressants like azathioprine are considered in patient with refractory disease. If we talk about the complication quickly, iron deficiency anemia, osteoporosis, infertility, neurological problems secondary to malabsorption because of the vitamin deficiencies, and intestinal lymphoma which can present 10 to 15% of the patient. Thank you.